When a heart rate exceeds 150 beats per minute, the window for ventricular filling narrows, and the myocardium quickly reaches a point of physiological exhaustion. We identify this state by checking for 4 specific markers: hypotension, altered mental status, acute heart failure, and ischemic chest pain. The presence of any single one defines the patient as hemodynamically unstable. In an unstable patient, there is no time for pharmacologic trial and error. The standard ACLS response is to abandon drug-based logic and move immediately to direct electrical intervention. If the patient is stable, however, we use the ECG to categorize the rhythm. We systematically determine if the QRS complex is narrow or wide, and if the RR interval is regular or irregular. These measurements dictate the specific medication we select. Memorizing these branching paths is only the first step. Clinical mastery requires understanding the anatomical reasons behind the protocol, allowing you to avoid the specific failure points that occur when a diagnosis is based on the monitor rather than the patient. The tachyarrhythmia algorithm first splits based on the width of the QRS complex. A narrow complex indicates the signal originates above the ventricles, utilizing the rapid His-Purkinje highway. A wide complex means the origin is ventricular, where electricity must travel slowly through the myocardium. Narrow, irregular rhythms like atrial fibrillation require a choice between 2 strategies. Most practitioners prioritize rate control, using beta blockers or calcium channel blockers to slow the AV node. The alternative is rhythm control, using agents like amiodarone to actively restore a normal sinus rhythm. This ECG strip shows the hallmark of atrial fibrillation. Notice the absence of distinct P waves and the irregular spacing between the R waves. This irregularly irregular pattern is the result of the AV node being bombarded by chaotic atrial depolarizations. Because the fibrillating atria do not contract effectively, blood can stagnate and clot. We use the CHA2DS2 VASC and HAS blood scores to quantify the risk of stroke versus the risk of bleeding, which determines whether the patient needs long-term anticoagulation. In wide complex pulseless rhythms, specifically ventricular fibrillation and ventricular tachycardia, there is no effective cardiac output. These are medical emergencies that require immediate, unsynchronized defibrillation to reset the heart's electrical gradient. Torsades de points is a specific polymorphic VT characterized by a QRS axis that appears to twist around the baseline. Often triggered by a prolonged QT interval, this rhythm is treated with intravenous magnesium sulfate to stabilize the cardiac membrane. This case highlights paroxysmal supraventricular tachycardia, or PSVT. The regular, narrow complex rhythm often stems from a re-entrant pathway near the AV node. In a hemodynamically stable patient, we attempt to break this circuit with vagal maneuvers or a rapid push of adenosine. However, if this patient suddenly develops hypotension or chest pain, the priority shifts. We move away from adenosine and perform synchronized cardioversion immediately. The drop in blood pressure overrides the pharmacological protocol. In any tachycardic presentation, the patient's perfusion status, not the complexity of their ECG, determines the speed and nature of the intervention. Bradyarrhythmias and AV blocks are physical delays in the heart's electrical transit. To treat them correctly, we must map the ECG findings to the specific cardiac structures where the delay is occurring. As the electrical signal travels from the atria to the ventricles, the PR interval records its transit time. This animation shows the signal slowing as it passes through the AV node before accelerating into the His-Purkinje system. First-degree block and Mobitz type 1, or Wenckebach, are typically reversible delays occurring within the AV node itself. On the monitor, Wenckebach is visualized by a PR interval that progressively lengthens until a ventricular beat is dropped. Second-degree Mobitz type 2 is a much more serious finding. This is an intermittent structural block located deeper in the His-Purkinje system. It drops ventricular beats suddenly, without any prior PR prolongation, indicating a failure of the conduction hardware itself. In third-degree heart block, the dissociation is complete. The atrial and ventricular signals ignore each other entirely. The ventricles must rely on their own slow, intrinsic escape rhythms to maintain any amount of blood flow. This anatomical mapping explains a common clinical scenario: an asymptomatic patient who shows Mobitz type 2 on a routine ECG. Because this block is located in the structurally unstable His-Purkinje system, it has a high probability of progressing to complete asystole without warning. Even without symptoms, this finding necessitates the placement of a permanent pacemaker. Identifying the anatomical level of an electrical block is the only reliable way to predict whether a patient is at risk for sudden cardiac death. Electrical integrity means little if the heart is physically prevented from filling. Mechanical cardiogenic shock occurs when the myocardium is intact, but external pressure stops it from expanding during diastole. Acute pericarditis is an inflammation of the surrounding sac. It presents with sharp, pleuritic chest pain and diffuse ST elevations. Because the issue is inflammatory, we treat it with high-dose NSAIDs and colchicine to reduce the swelling. If fluid accumulates rapidly within that sac, the pressure can exceed the heart's internal filling pressure. This is cardiac tamponade. As shown here, the fluid physically collapses the right ventricular wall, preventing blood from entering the heart. This collapse leads to Beck's triad: hypotension, muffled heart sounds, and jugular venous distension. A key diagnostic finding is pulsus paradoxus, a drop in systolic blood pressure greater than 10 millimeters of mercury during inspiration. In chronic cases, the pericardium can become a rigid, calcified shell. This constrictive pericarditis causes a sharp Y descent on a venous tracing and Kussmaul sign, where jugular veins distend during inspiration. This requires surgical removal of the pericardium. We distinguish these from myocarditis, which is an internal dysfunction of the muscle itself. A patient with myocarditis often has a viral history and elevated troponins, but their heart is weak and dilated, not physically restricted from the outside. If a patient presents with dyspnea and a 14-point drop in systolic pressure on inspiration, they are in a mechanical crisis. Medical therapy will not help. The patient requires emergent pericardiocentesis to drain the fluid. Mechanical restrictions demand mechanical solutions. When the heart is physically compressed, decompression is the only way to restore hemodynamic stability. Many cardiac emergencies present with overlapping features, creating a risk for cognitive errors if we rely on a surface-level interpretation of the monitor. Consider ventricular fibrillation. If a practitioner attempts synchronized cardioversion, the machine will search for an R wave to lock onto. Since VF has no R wave, the device will never fire, causing a fatal delay in the required unsynchronized shock. In a Mobitz 2 block, atropine is dangerous. It stimulates the AV node, but the signal hits the structural dead end below. Also, giving a diuretic during tamponade is catastrophic. It lowers venous pressure needed to fight external fluid, causing the right ventricle to collapse instantly. Finally, we must differentiate inflammation from ischemia. The ST elevations of acute pericarditis can mimic a massive MI. If we misdiagnose this and administer thrombolytics, we risk causing a massive hemorrhagic effusion into the pericardial sac. Solving these cases requires us to separate electrical circuitry issues from anatomical conduction defects and physical mechanical restrictions. Board-level mastery is not about the rote memorization of flowcharts. It is about deeply understanding the physiological failure modes that those flowcharts were designed to address, ensuring the intervention matches the true underlying cause.